All right. Hi, everyone. On behalf of HR.com, it is my absolute pleasure to welcome you to this webcast, Innovation and Inclusion, Essential Tools to Improve Diabetes Care and Cost Management, sponsored by Diabetes Leadership Council and JDRF. This webcast has been pre-approved for 1HRCI credit and may also be submitted for SHRM credit. Please be sure to attend the complete webcast in order to receive your credits. You'll receive an email from HR.com within 2 business days, which will include your certification information. You can also go and to your own profile and see the credits that you have received there in the View My Credits page. It's the top right-hand corner of your profile. During the webcast, we have a great panel for you today. So we do hope that you have some questions or some comments. Please make use of the Q&A in your webinar controls. Type your questions or your comments in there. We've also enabled the closed captioning function. If you'd like to turn it off, please click on live transcript and hide subtitles. And again, thank you so much for joining us. We're in for a treat here. It is now my pleasure to turn it over. We're going to get us started. George Huntley and Aaron Turner-Phifer.
Thank you, Rhonda, and good afternoon, everyone. I'm George Huntley. This is my good friend, Aaron Turner-Phifer with JDRF. Aaron, say a few words about yourself, and I'll do the same. I'll let you, you're on the left-hand side of the screen, so I think you should go first. Oh, you're muted, sir.
It has to happen at least once a day. Aaron Turner-Phifer, Director of Health Policy at JDRF. And just a short blurb about JDRF. We are an organization focused on finding a cure for type 1 diabetes. And I'm part of the health policy team that is focused on making sure that innovations, improving the lives of those living with type 1, make it into the hands of those diagnosed with type 1.
Super. And Aaron, it's a pleasure to be working with you again on this project. I'm George Huntley. I'm the Chief Executive Officer of the Diabetes Leadership Council. I am a patient living with type 1, have been living with type 1 since 1983, have other family members also with type 1. I have been a diabetes advocate for 30 plus years. The Diabetes Leadership Council is an organization solely focused on advocacy for patients with diabetes. We are a policy shop. That's all we do. And it's a pleasure to be with you all today. Also, in my other day job, I'm the Chief Financial Officer of a professional services firm based out of Indianapolis, Indiana. And in that role, I have been the plan administrator of a self-insured health plan for over 20 some years. So I have the payor perspective of this and have lived both the patient and the employer side of it. So with that, let's go into the objectives for the day. We're here to understand how diabetes impacts health plan risk and the costs and the impact on communities of color. We're going to hear about some innovative and individualized approaches to diabetes management and prevention. We're going to learn from some employee benefit experts who will have aligned incentives to keep the employers, the insurance companies, and the pharmacy benefit managers all in sync. And hopefully we'll give you some takeaways for some key health plan design features that you can use in your designs going into the 2022 plan year. And we're going to kick it off with a state of diabetes care and coverage, and I will turn it over to Aaron to walk us through this section and give us an update on what is the current state of diabetes. And I'll turn my camera off.
Thank you, George. And I'm going to run through this because I want to make sure we have lots of time for our great guests who are going to join us today. But just quickly, as of today, 34 million Americans are living with either type 1 or type 2 diabetes, and that includes 1 in 8 adults. Diabetes continues to be one of the leading cost centers in our national delivery system. $1 in $4 spent on healthcare in 2017 was spent on a diabetes-related issue. And a survey of large employers last year found that diabetes was one of the top 4 concerns around health plan cost. And so you can see, from a broad perspective that diabetes is a concern, and this is probably not news to many of you. And we'll move on to the next slide here. Diabetes itself is a chronic and progressive disease. There's not a cure right now. And so folks living with diabetes have to manage their disease day to day. There are therapies available that prevent or delay serious complications. And these complications tend to be the things that we see some of the most expensive claims come through from a health plan perspective. But these complications are also the things that have the greatest impact on the quality of life and honestly productivity in the workplace of folks living with diabetes. And so just to highlight a few of the most serious complications associated with diabetes are diabetic retinopathy, heart disease, kidney failure, and lower limb amputation. And we'll scoot on to the next slide here. Just a couple of key notes before we move to some CDC data. The vast majority of folks diagnosed with diabetes are diagnosed with type 2 diabetes. A minority of folks, 5 to 10%, diagnosed with type 1. I want to highlight that of the folks that are newly diagnosed with type 1 diabetes, around half of those tend to be in cases of children. And so it's possible that there are employees of yours enrolled in your benefit plan that are very concerned about the diabetes coverage, but they're concerned about it for their kids' sake. And it goes without saying that something that impacts your child can be as disruptive to your life and certainly your work productivity. And so as we're building and as we talk to folks about building out a benefit plan, we encourage folks to keep in mind that while small relatively in numbers, the needs of the children with diabetes as well is something to keep in mind in terms of how you're structuring your benefits. Another important point here is that we know diabetes disproportionately impacts communities of color. Here on the right-hand side, you can see the percentage of diagnosed diabetes in U.S. adults broken out by race and ethnicity. One key point here that we encourage folks to keep in mind is that while we encourage broad coverage of therapies that help manage someone's diabetes, it's also important that we keep in mind ensuring there's access across communities to these therapies. We know and studies have shown that even when coverage is provided, there tends to be less access in certain communities. And so that's an important component to keep in mind as you're considering and you're working with your vendors to consider out building your benefit plan. One note, as we hopefully are quickly moving through this COVID-19 pandemic, one thing to keep in mind is data shown that those living with diabetes are at a higher risk of severe complications should they get COVID. And so that's something that we're going to be keeping a close eye on. There could be downstream costs associated with COVID complications for those living with diabetes into the future. So something to keep in mind. And let's jump here quickly. I want to highlight just a couple of key points on this slide. As a reminder, there are 34 million Americans living with diabetes today, and the CDC is reporting that last year there were 16 million emergency room visits related to diabetes. Now, I'm not saying that 1 out of every 2 of those people with diabetes went to the emergency room, but this volume of emergency care visits related to diabetes is somewhat staggering and a bit surprising to us, and it highlights the amount of room for improvement and effort that's required here. As you all know and are aware of, an emergency room visit is one of the most costly, if not the most costly, claim to come through. And so any effort that we can put on to better support those living with diabetes to ensure they stay out of the emergency room, not only likely is improving their health, but it's also going to save the health plan some money. I want to note here we know that a lower A1C and folks achieving their A1C goal is not only better for their health in the long run, it's better for the financial health of the benefit plan in the long run as well. And there are therapies that we're going to talk about here briefly that can help folks achieve these A1C goals. And specifically want to highlight that 89% overweight or obese, that's a key indicator of one's ability to reach kind of that A1C goal and a healthy lifestyle. So, focusing on benefit plans that support tools and therapies to help folks better manage their weight is something that we are increasingly paying attention to. It's an important indicator of better health for both the plan and the person. So with that was a quick run through of kind of a landscape. I want to bring in our 2 distinguished panelists, Dr. John Anderson of the First Clinic in Nashville, Tennessee, and Donna Ryan from Ascension Health in Pensacola, Florida. Thank you both for being here today. And I'm going to start with John. You just want to quickly introduce yourself and tell us a little bit about your clinic.
Thanks, Aaron. My name is John Anderson. I practice internal medicine and diabetes at a large multi-specialty clinic called the Frist Clinic, which is an HCA facility here in Nashville, Tennessee. So thank you for having me on.
Thank you, John. And Donna, do you want to introduce yourself and tell us a little bit about Ascension Health?
Yes, hi, I'm Donna Ryan. I'm a registered nurse as well as a certified diabetes care and education specialist, and I'm the director of the diabetes programs across the Gulf Coast here in Ascension, Florida. We serve pediatric and adult patients, inpatient, outpatient.
Outstanding. Well, thank you both. I'm very excited to have this conversation with you today. And Donna, you get the first question. Just for the audience and to set the stage, can you just describe in a bit of detail what successfully managing your diabetes entails for the patient? What is that? What goes into that?
Great question. And we'll start off by acknowledging that diabetes is a patient-managed disease. They live with diabetes 24 hours a day, 7 days a week, 365 days. And there are, and I believe you have a slide here to show 42 factors that affect glucose, blood glucose, also called sugar, that need to be managed and to be successfully managed. Medications, physical activity, nutrition, stress reduction. There is a lot of factors that cause the up and downs of blood sugars. So services that are helpful and that we provide for helping success with these with diabetes is education, self-management, behavior change, nutrition counseling, psychology or stress reduction, and as well as, and I believe you have a slide here also, Aaron, for the tools to manage diabetes. So there are now, we have some wonderful technology, and technology is only as good as our understanding and our ability to use it. Glucose monitoring has been around for quite a few years, the poke your finger machines that everyone's aware of, but we have in technology advanced to continuous glucose monitoring, which is a 24-hour a day monitoring system for diabetes. So there's a lot that goes into it. I do want to also say how important it is for a good regular medical care for people with diabetes, and an understanding of the impact of the timing of medications and nutrition on what is causing those blood sugars. The data that you showed earlier about complications in the ER visits, I'd like to point out that comes from, we see that with people who are not successfully managing their blood sugars. When you successfully manage, meaning that you have a good medical team, a good physician, a good education, the right medications, and a diet plan and support from family and at work, we have much fewer complications and better outcomes.
Thank you, Donna. That's a great overview, and I want to tie a string together on a couple of things that you just said around. I think we think of it as innovative technology. It's been around for the better part of a decade, this idea of continuous glucose monitoring, but it's really started to take off. And I think there's some data that's been published relatively recently showing the tremendous value. Can you just talk about that? It's a relatively small device. Can you just that a person wears, and it's an information feed. And so what you had just mentioned around giving them the tools and information they need, can you just talk about what this technology has meant for helping folks just be aware of what's required to successfully manage their diabetes?
It has empowered people to better see and understand the impact of their choices with medications and food and what it does to their blood sugar. A continuous glucose monitor, and I don't know if the audience is aware, is it's a tiny sensor that's inserted under the skin. It can look like, as you see there in the picture, it can be the size of a quarter or smaller. It's very unobtrusive, but it's a constant feed. Every couple of minutes, it feeds the glucose to a monitor. In some cases, the monitor is an insulin pump or a small device like a PDA, or now on the cell phones. And so, going back to your point about pediatric, and many of our associates have children with diabetes. They're able to see their child's blood sugars over the night while they're at school and while they're away. That's huge on the stress factor and the management for parents of children. And then as adults, when we wear them, we're able to see the impact of, I don't know, if you eat French fries and a milkshake along with your lunch an hour or less later, you can see the impact of that. And it helps with understanding that your actions result in a blood sugar that's either maybe higher than you want it to be, or if you don't do the timing in the food, maybe it's lower than what you can expect. So it's a safety, it's a safety net. That's what it means, I believe, for a lot of people. And we've seen some pretty remarkable behavior changes just based on people being able to see in real time what their blood sugars are doing in reaction to whatever the meal or the activity is that they're doing.
And Aaron, if I might add,
please.
even, we've had pretty unnecessarily restrictive rules about our adult type 2 patients on what hoops you have to jump through and that type of thing to qualify for a CGM. But what we've seen, multiple studies show that if you take a type 2 patient, to Donna's point, who is naive to monitoring their glucoses, there is tremendous behavior change with these. And we will see A1Cs lowered without any change in medical therapy, simply because of the feedback that it gives the patients. And in addition, for those patients who are on agents like insulin or that have the potential to cause low blood sugars, these devices now have alarm features that can alarm them if they're getting close to being hypoglycemic, that is a low blood sugar, and a high blood sugar. And, when you referenced those emergency room visits, having the ability to treat a low episode before paramedics are called is not only great for the patient, but it's cost saving as well.
Yeah, that's such a great point. And I think now would be a great time to pull up our poll we have for the audience here. And we really just want to hit this point around the potential of savings for, the poll pop up on my screen, I couldn't see anyone. But this is, I think, a tremendous opportunity. And one thing I would highlight, what we've been working with insurers on is this is not necessarily new technology. It has iteratives, and the most recent versions of it are quite amazing. And coverage has come a long way. And so for those benefit plans that are restrictive or haven't given special consideration to this, you're really missing out on a tremendous opportunity here for not only cost savings, but to improve the lives of those on the plan. And so, Ron, I don't know if we've got the results in.
Yep, for sure. I can end it here. Thank you, everyone, for responding. And there's your results, Aaron.
All right, and so let me, so folks can get a sense of the responses. Let me go ahead and read the question and the responses real quick. And so in a recent study of 571 people with type 2 diabetes, what was the financial impact of using a continuous glucose monitor? Options were a net cost of $425 a month, a net cost of $53 a month, net savings of $53 a month, or net savings of $424 a month. And we go to our next slide here, and you can see the results. So $424 a month in net savings for those using a CGM. So, it's hard to find that level of savings in your health plan. And so this is, at least in our sense, a no-brainer. It helps the plan's bottom line. It helps patients at the end of the day. And so in the time we've got left, I do want to shift gears a little bit. I know when we're talking innovation, we're usually talking about a device, or we're talking about a drug. And I should make a point to come back to this actually before we leave CGM. This is some of the information that's displayed. And I think, and Donna and John jump in here, what's compelling to me is that it's easy, not knowing much about anything about the CGM or the device, it's easy to convey what's happening to your glucose levels just through this graphic. And so I'm not sure if either of you have had experience working with patients around this and kind of their response.
Sure. I mean, what you see on that first, what we call an ambulatory glucose profile, is a high degree of big fluctuations. And you can see that the arrow bar is wide. So there's multiple variability. And then through whatever therapy is chosen plus behavioral modification, you can see what we're looking at, which is a very flat profile with a very narrow variability. And that, again, emphasizes the fact that the patient's likely under better control with less fluctuations that can put them at highs or lows that are costly.
Exactly. And this also is like a detective game. The patient can see it, but typically it's the physician or the clinician that looks at this, and we uncover hidden hypoglycemia events that are happening unbeknownst to the child or the person sleeping through it. So in doing this, I'd go as far as saying it can also, it's life altering and life changing when you uncover that every single night someone's blood sugar is dipping into a dangerously low range. And so without this, we wouldn't discover that. And then we make the medication adjustments or whatever needs to happen.
I think this is an amazing and dynamic tool, and I think it goes hand in hand with, I mentioned you were talking about devices when we talk about innovation, but hand in hand with some of the, I think, innovative drugs that have just hit the market or are coming to the market. And so I think this is a question for both of you. John, I'll cue you up first.
Okay.
What are those drugs that that you either are deploying in your practice or patients are looking forward to that you see being a real asset, not only for managing glucose levels, but also like what follow-on benefits to some of these drugs in terms of lifestyle?
It's a great question, Aaron, because it is a completely different era of medication with diabetes. You saw that we only have 50% of our patients at goal, and that hasn't really changed. Those are HEDIS measures. I think it's largely because a lot of the better medications are more expensive and there's limited access. You have GLP-1 receptor agonists that exist in a daily injectable, a once-a-week injectable, and now an oral form that have associated with them lower cardiovascular risk. That means less cardiovascular death, heart attack, and stroke. Think about the cost of those complications, reducing it over a 3-year period by 13%. The SGLT2 inhibitor class, what we are finding across the class is that hospitalizations for heart failure are reduced 30 to 35%. Kidney function now is being preserved by these SGLT2 inhibitors. So you can monetize a reduction in a 30 to 35% decrease in heart failure admission to hospitals. And so when we look at these more expensive medications, you have to also balance that with what is the overall cost and what are we trying to prevent? And the reduction in both macrovascular cardiovascular disease, the reduction in microvascular disease more than pays for itself for the cost of these medications.
Donna, as we wrap up here, I think I would just ask you to kind of, wrap for the audience around the importance of getting access and maybe some of the barriers that you run into and some of your patients run into getting access to some of these innovative therapies.
Sure, and what I'd like to add to what John just said very well is that these drugs also reduce that average blood sugar, the A1C, and weight. And when you reduce the weight and the blood sugars, you reduce the complications and then downstream the healthcare. And when you combine these medications with that continuous glucose monitor, now you have more of a sustained, the medication's doing what it needs to do, but the person is learning what the impact of their actions are. And so we have a double behavior change along with the weight loss and the A1C. Throw in some diabetes education, which is essential for long-term support for these improvements in health, and you've got a trifecta of better diabetes management. So some of the challenges that come into play is at the beginning of the year, patients not being able to meet their deductible, and therefore there's a lot of out-of-pocket for having to get the medications and to get the continuous glucose monitor and the other items that they need for checking their blood sugars and taking care of themselves. That's a barrier. At work, there's a challenge in many, and with some of our associates here with that rapid fire job that you have of checking your blood sugars if you're doing the finger stick, and the CGM allows them not to have to stop and check their blood sugar when they can look at the monitor. And there's challenges also with when formularies change. And so these tools and medications that work so well that you and your doctor figured out, and you're doing well, and it changes. And so now you have to start all over, especially if the insurance formulary makes you start with a lower cost medication before you can get back to the medication that's already proven to you. So that frustration level can be an inhibitor to continue to try to take care of yourself because you're not getting the results because you're not on the medications or with the tools that you have. I hope that answered that question.
No, that's a great answer and a great segue into our next segment here, where George is going to walk us through some of the benefit design considerations to make sure these therapies are available to folks. So Donna, John, thank you both so much for being here. It's been very insightful. Appreciate your time and all your hard work, folks in our community. So with that, George, I think we'll hand it off to you.
Well, thank you, Aaron, and thank you also, John and Donna. Great session, great conversation, and such important information. So let's now we're going to shift our conversation to some of the marketplace dynamics that are happening and that are influencing diabetes care and costs, and frankly, influencing a lot of things beyond just diabetes. But we're going to focus on diabetes today. And we're going to start with the price of insulin. Insulin's in the news. If you're hearing about people complaining about the cost of prescription drugs, insulin tends to be one of the first and loudest parts of that conversation, because if you have diabetes like myself and you don't take insulin, you don't live. So it is a drug that is needed for basic survival. But in a marketplace, typically when you see competition, and there's competition that's increasing, there's multiple providers of the brand names drug. There's three different versions of insulins that are out there. There are biosimilars that are now on the market. So there's actually more than there's three brand name drugs. There's biosimilars that are coming. And just recently, within the last month, there was the first interchangeable biosimilar put on the market. And it's an interchangeable for the long-acting Lantus that's out there. Some of you may be familiar with that product. So it's the first biosimilar that is interchangeable. We talk about shifting a drug from one to the other, which happens on formularies all the time, which drives a lot of patients nuts because I'm on a therapy that's working for me. This is the first one that's actually been approved to be interchangeable by the FDA. But you in a scenario where competition is rising and net prices are falling, which is normal, right? So prices drop when competition rises. That's the free market economy. But list prices have been going through the roof during this period. Now, the dollars that you're seeing here, this is me personally buying insulin in February of this year at a CVS in Noblesville, Indiana. So this is personal experience from the CVS receipt when I bought 6 vials of insulin in February of 2021. Because of these list prices, we're seeing 1 in 4 patients reporting cost-related rationing. These are people who are not taking the correct amount of insulin, the amount they need in order to actually manage their blood sugars, because they simply can't afford it. My plan, because I'm the administrator, I passed through those rebates. I paid $85 per vial for the 6 vials. It should be even lower, but I paid $85, but many people are paying $334. So let's look at what's happened with list prices and what's driving it. And what's driving it are the rebates. So the manufacturers, and this is information given to Congress and from a U.S. Senate Finance Committee report on insulin. You're looking at the list price of insulin. This is a long-acting insulin from 2012 to 2020. List price went up, more than doubled, 141%, from around $150 to well over $300. In that same period of time, the net price of insulin dropped 53%, from $100 to nearly half that. So what's all this money in between? The money in between are the rebates that the manufacturers are paying to the pharmacy benefit managers. These pharmacy benefit managers are charging an access fee, a market access fee to the formularies. This is where you get into where they're going to cover 1 long-acting insulin, 1 short-acting insulin, 1 cholesterol medication, 1 blood pressure medication. They're going to be coming out with their singular options for the formularies, and the manufacturers are buying in to the formularies. So when you buy a vial of insulin, I'm going to go back a slide, you've paid $334, and most of that money has gone to the pharmacy benefit manager, who then sends it through to the insurance company, and it likely comes back to your employer. And so the employer is getting most of that rebate back. So the employer is paying pretty much the net price, but the pharmacy benefit manager is keeping a slice of it. And that is why they are continuing to push this. And they have an incentive to actually put the higher list price drug on your formulary, because they want to get a piece of that rebate. So now you have to think about your plan design and what do your employees get charged for chronic disease management. And these are 4 very real plan designs that are out there today. So some plans, we're going to talk about this in a little bit, first dollar preventive coverage and giving away insulin for free. And there's CVS has RX0. They're a plan that they've put together. They actually did the math and said an employer can actually save money by giving insulin away because it is so much cheaper to manage diabetes than it is to pay for the complications. It's that much cheaper. You just saw it on the CGM value for a type 2 patient. This is not a type 1 patient that they did that study on. This is a type 2 patient that saved $400 and some a month because it saved that much in hospitalization costs. So their big justification to basically giving the life-saving drug away, $25 copays, that's very normal. A $25 copay is not abnormal in a plan, and nobody would really complain about paying $25 for insulin. You get into a co-insurance situation where now you're paying a percentage of the cost of the drug. And then the question is, a percentage of what? Are you paying a percentage of list price, or are you paying a percentage of the net price? And that makes a huge difference to the patient. So if you're paying a percentage of the net price, then you're looking at $360. Still a steep bill, mind you, but it is a lot better than $1,200 a month if you're exposed to full retail pricing during the deductible part of your drug. So, and far too many people are actually, you're fully insured, you've got a plan through your employer, and they're paying $1,200 a month or more for access to their insulins. And many people need multiple insulins. If you're on multiple daily injections, you need long acting and short acting. Some of the type 2s need that as well. And very few people take just one drug. So you're looking at somebody who now has a monthly payment that, depending upon their economic ability and how much you pay your employees, this becomes hardship. So we're going to move to a poll question here and ask, does your organization offer at least one plan with rebate pass-through, full rebate pass-through to your plan members? And it's okay to not know. It's okay to not know. But as an employer, we're going to talk about, managing this process because this is your plan. So, do you think you've got, one plan where you're passing through all of the rebates to the plan? So is your plan like mine? Is your participant paying $85 or are they paying $300 in the process? So let's see what people said. And the answer is 18% say yes, that they are passing through at least one plan. They're passing through full rebates to the employees. 18%, similar numbers, said, no, we're definitely not passing it through. We're charging list price. And 64% didn't know. And that is actually not abnormal. But I would encourage you to look into it because this is something that impacts your employees' ability to afford their drugs and afford their coverage. And so I encourage you to manage your PBM like a vendor. They are your vendor. They work for you. And if you don't know, then find out. But also understand, and you just saw it on that poll, you're not alone. If you don't know, 64% of the folks on this webinar don't know. There's a lot of folks that really don't know what you're really getting with that. So let's talk about some key plan design features that we're gonna discuss today, and I'm going to start with pre-deductible coverage. So the IRS in 2019 came through on a high deductible health plan. They said it is okay to treat chronic disease management as preventive care, therefore pre-deductible. And I would encourage everybody on the call to consider that on your plans. That's probably the biggest step you can take. Bypass the deductible, make them, copays are fine, but bypass the deductible and allow people to have the tools to manage their chronic disease. It is in their best interest, but as importantly, because this is about the employer, it's in your best interest for them to do it. Give them low predictable cost sharing so that they don't have that surprise January, oh my gosh, here's a bill with a comma, and that's just insulin. That's not the pump supplies, that's not the CGM supplies and sensors, that's not seeing the doctors and the lab fees, et cetera. Make sure that your employees dealing with chronic disease have the tools and the spread of that cost so that they can afford it. It's better for you. Pass through rebates. Now, this is more than just diabetes. It's more than just insulin. Eliminate list price exposure to your population. They're paying a premium to get access to your plan. They've paid a premium through payroll deduction to get access. They're getting the benefit of your discounts at the hospitals, the doctors, the labs, et cetera. But unless you pass those rebates through, they're not getting any value for your plan until they've met their deductible fully. They may as well just go to a good RX and buy it offline, except they don't get any deductible credit for doing that. So I really encourage you to look hard at this. And then treatment choice. We touched on this, that Donna and John touched on this. There are many different insulin pumps out there. There are many different continuous glucose monitors out there. They have different features, et cetera. The patients dealing with this 24/7, don't force them into a one-size-fits-all scenario. It doesn't work well. So I encourage you to ensure that you're not limiting those choices to the people. So I'm going to do a second poll question here. Does your organization offer at least one plan with first dollar coverage, pre-deductible coverage for chronic disease management? And this, again, you may not know. You may be sitting here going, I don't know this. I hadn't really thought about it. The IRS in 2019 said it could be done, but it was a may, not a must. And our presentation here is to say it really is a should. You should want to do this because it is going to save the employer funds, and it's going to really help your employees and their families. Rhonda, what did they think? And similar, 14%, only 14% said yes, that they do have at least one plan that had first dollar coverage. 23% said, no, we do not have a plan that has first dollar coverage. And the same 64% don't know. So that's something that I would encourage you, again, to take a look at as you go forward here. This is, again, your plan. So we're going to talk about penny wise and pound foolish plan design. This is a very disturbing statistic. 34% of families with employer-provided insurance ration medical care. That's 1 in 3, more than 1 in 3. That's actually 1 point more than the uninsured. So the employers have an issue here, and employers cover more than half of Americans. So the employers have a responsibility for America's health, even though that's not our job. Our job is to be in whatever business, service, manufacturing that we're here to do. But based on our health system, employers are responsible for 50% of Americans' health. 1 in 4 people with diabetes report cost-related insulin rationing. So we've got a lot of people rationing when they are in fact insured. We're also spending money inefficiently. Over 60% of diabetes-related medical expenditures are on the complications. These are the heart attacks, the strokes, the retinopathy, the kidney disease, the amputations. We're spending money on that. Over 60% of it is spent on that versus the management of the disease. 2 times spending on prescription for complication treatments versus management of the disease. Then we touched on this on the last panel. There's a stigma around obesity, and obesity is a strong driver of diabetes. Everybody understands that. About 80 to 89% of people with diabetes are overweight, or obese. That's very, very common that those two go hand in hand. Most plans will cover bariatric surgery or perhaps some therapy, some counseling, some nutritional therapy, maybe. But there's really nothing covered in between. But there are many options that are now on the market that will help people lose weight and get out of that obese category. We also know at this stage, and it's important that I share, that losing 5% of your body weight and exercising 30 minutes can actually reverse type 2 and certainly can prevent many of the complications. You don't need to lose 100 pounds. You need to lose maybe 10, 20, 25 pounds, depending upon how overweight, how obese the patient is. Those are achievable goals. But we also know that dieting simply doesn't work. Dieting alone does not work. And this is a metabolic disease and metabolic condition. It's not the patient not following doctor's orders and not being adherent to their therapies. We need to treat this as the chronic disease that it is. So I urge you to consider that. I'm now going to turn to our employer panel to talk about, and I'm going to invite Karen and Lori to turn their cameras on at this point, to talk about some plan design and talk about other things that an employer can do to accommodate people with diabetes. So I'm going to stop sharing and I'm going to welcome Karen and Lori. And Karen Brust is an underwriting and sales professional at Business Administrators and Consultants, BAC. BAC is an independent third-party benefit plan administrator located in Central Ohio. Karen has been part of the employee benefit plan industry for over 35 years and has passion for helping employers and their team navigate the very murky waters of healthcare plan design. And Karen, it's a pleasure to have you with us today. And Lori Sweeney is joining us from Insperity. Lori has more than 18 years of experience working in the human resources field. She is a senior human resource specialist with Insperity. She's been with them for the past 4 years. Insperity is one of the largest professional employment organizations on the planet, with 70 offices and about $4.3 billion in revenue. It's far larger than my company. So Insperity has a breadth of clients of large and small. And Lori has been with them for 4 years, has been in the pharmaceutical and technology industries prior to that. She's been an HR manager and HR director, and we're going to talk in a few moments. I will turn to Lori to talk about things that an employer could and should be doing to make a person with diabetes successful and be a successful and productive employee. So welcome, Lori. Welcome, Karen. And I'm going to start us off with Karen talking about plan design. So Karen, tell us a little bit about maybe your recommended coverage approach to chronic disease management with your clients, what you see them doing from a cost perspective. How's that world changed and what's it look like today from your perspective?
Well, the world has changed immensely since I first started in this industry. But remember, I started a long time ago, thus the gray hair, and deductibles were like $50 a year. So now we're facing annual deductibles in the thousands of dollars. And it's not about managing a member and a condition. It's about managing a family and a family of conditions. And we can't look just at one person, just at one disease state, because in that family, there are multiple chronic conditions, most likely. So diabetes covers a very broad category. And you've got to have the data. You have to, as an employer, be able to access the data and start looking at what is driving the cost to your plan. And when we look at the average spend, and this is average, these are not chronic dollars. These are just average dollars for an average diabetic at over $20,000 a year. You have to put in programs that are going to help the member. And it's going to be different for every member. And that's the hard part. If you work with some of the larger insurance companies, it's really hard. They have a one solution plan. You've already spoken about it, George, and some of the drug issues, but you've got to start looking at what works best for that member and for their family. And so we've done a lot of different things. One of the really unique things that we've started doing in the last few years, and it just sounds odd if you talk to most HR professionals, but we are lowering copays across the board. If you make sure that the diabetic member gets care, what about the rest of their family? How are they accessing care? Are we giving up care for family members just so the diabetic can afford their care? Well, that's not smart either. So we have started taking plan designs and reducing or eliminating copays. I'll give you a perfect example. We have an employer plan here in the Central Ohio area, but they're a nationwide employer, and they have over $2 million medical spend each year. And this past year, they took and eliminated copays for all generic drugs. They put the high deductible health plan wellness drug list, which is pretty broad, across all their plans, not just their high deductible plans. And that drug list includes both brands and generics, and in the diabetic category has over 50 oral medications. Those are all zero copays. Moreover, we took office visits that were a $40 copay and reduced it to a $5 copay. George, I liked your slide, and it showed a $25 copay as a good plan design. But remember, members with diabetes are probably going to see the doctor 4 times a year. And if they have any other chronic conditions associated with that, they may be going to see a doctor every month. Now, one of the things that we've done to help not only the issue with the member, but also the employer and the presentee issue is to say to that member, gosh, could we get you to see a single doctor for all of your labs and push that data back out to your other chronic disease specialists so that these members are not going to the doctor every month, every other month, but still that data is getting into the hands of the people that needs to. These plan designs that I'm talking about are not expensive. It really is smart dollar spend. We're talking about 1 to 2% of the overall drug spend. In the employer I was talking about, $2 million in annual medical spend, the cost for that plan design was $35,000. We're talking about a huge impact to a broad group of people, not just diabetics, but across all plan designs. We need the members to get good access to care.
And you're looking at a $2 million plan. The employer is making a decision saying, okay, I'm going to invest $35,000 so that my employees can have access to the drugs and the services that they need. And the employer is betting that that $35,000 is going to pay them back 2, 3, 4-fold by not having to pay for the complication, which is so much more expensive. It's so much more expensive than any of the other tools that we've talked about, whether it's a CGM, insulin, et cetera. But they may also hopefully be a better employee because they're healthy.
Yes. Yeah. And let's face it, guys, today's environment, it's really hard to get and retain employees. So let's start pushing some of these solutions out there to not only help members with chronic conditions, but help yourselves get and retain employees. George, one of the other issues, if I could jump in, is the cost of stop loss. The cost of stop loss is so expensive, and the stop loss carriers out there have said that the cost of complications for diabetes is the third to fourth largest spend that they have for multi-million-dollar claims. So if you look at a patient with end-stage renal disease, that cost could range from $200 to $3 million to that stop-loss carrier. So putting these plan designs in gets the attention of the stop-loss carrier as well.
And are you getting a discount that is your client getting then for paying less for the stop loss or seeing less of an increase?
Yes, exactly right.
Yeah,
Exactly right. And it depends on the carrier, but both and.
That's great. One, before I pivot to Lori and want to talk about what the employers can do, one last question on rebate pass-through. What has been your experience on that with negotiating with PBMs on behalf of your clients?
Yeah, there are some PBMs who offer a transparent model, what they call a transparent model. That's not truly transparent. It's not truly passed through. So you have to really spend some time and use the experts in the field to find those organizations that will do a true pass through. Now, on our plans where the employer has reduced and eliminated copays, we're not as concerned if that employer wants to work on a rebate model. We are concerned that the employers get the rebates and not the insurance carrier, though.
Yeah, great point. Great point. It takes a negotiation. Well, thank you so very, very much. And I'm going to pivot due to time here, and because I would love to keep talking about that topic very much. Lori, if I could ask you to talk to us a little bit about what you're discussing with your clients about accommodations in the workplace to make them more productive while they're there and have them be there longer, if you will.
Thanks, George. Yes, I would love to do that. And because I do spend a lot of time talking to my clients, and like you said, small to mid-sized businesses primarily in all different industries. So I see a lot of different challenges. And kind of turning things a little bit, because you talked about the technology and you've given everybody a lot of great information and resources to go back and really dig into those plans and see what their health plans look like. I want to talk a little bit about how you, like, as an employer, as a manager on the floor dealing with employees, I want to make the business case for how important it is to promote and support the wellness of all of your employees, not just people with diabetes, but just caring for your employees, giving them the opportunity to be a little healthier, or giving them those incentives to be a little bit healthier. It's going to have an impact to your bottom line, right? A healthier workforce contributes to lower healthcare costs. You guys have made that very clear with the numbers that you've shown. But it's also important to remember that when you have an employee with a medical condition, such as diabetes, you do have that legal obligation to treat them fairly and make those accommodations for them. So even if we haven't given you every reason to want to do it already, and because you want to care for your employees, you have that legal requirement. So now we're telling you, you really have to. So I think everybody is aware, the Americans with Disabilities Act, the ADA, it tells employers you have to open a dialogue, and that's called the interactive process, to work with an employee who has some kind of physical or mental condition, something like diabetes, to determine what can you as the employer do to help them perform their job. That's the accommodation. And, think about this too. It's an ongoing open conversation. It's not a one and done sort of thing, right? Employees' needs change. Work needs change. So you need to remember that this is going to be something that you are coming back to and talking to your employees multiple times about, probably. And I want to say, because I've had this question a lot, employers ask me, well, what can I ask? Should I ask them for their doctor's advice? It's okay, and it's even necessary for you to ask for guidance from your employee's physician if they have restrictions or they have special needs, so that you can figure out what the best accommodation is that will allow them to do their job.
And in many cases, I'm going to step in for a second as a patient, an employee, and a person living with the disease. In some of these cases, the accommodations are minor. I mean, if you're thinking about, I've got to check my blood sugar. Well, I have a CGM. I don't know if it's going to show up on the screen. It probably won't. It's a little glary, but it's telling me I'm 165 and steady at the moment, which I a little high, but it's steady, and I'm presenting, so I'm going to be a little high. That took me seconds.
Right. Right. And that's a great point, George. I was going to talk about that. Diabetics specifically might need more breaks or that ability to take a break at an unscheduled time. Now, something I've seen with call center situations, they don't want people to have their phones, or people who work in factories on the floor. They don't want them to carry their phones. That could be an accommodation that you say, yes, you employee, you have a particular need, and you can have your phone on the floor, so you can take that check if you're not feeling well, or you check your phone, check your monitor every hour. You know, and you can work with the employee. Maybe they need to have a special bag or a buttoned pants pocket or something like that to make sure that you're maintaining the safety of your workplace, but still accommodating your employee. That's where you're always talking to them. Other diabetics, and George, jump in if I miss something, but some diabetics who take insulin might need a temperature controlled place to store it if they work in a hot facility. True?
Very possible. They also may need a place to treat a low blood sugar. So if I have a low blood sugar, if that score had not been 165 and had been 65 and dropping, I would have had to deal with that right now. I can't wait till my break happens. I need to do it right then and there. And it's at my desk, I keep a bottle of apple juice. It's not just for kids. And I would have taken that very quickly, and I would have been back about my business. But having that, allowing the employee to have that at their desk, huge.
Can make a big difference.
You've given them the CGM, but then, you know, allow them to have the phone. The other real quick touch point on the phone, they may be a parent of a child with type 1. Aaron was speaking to this. So the phones, the parent can actually see their child's blood sugar while they're at daycare, while they're at school. So they can actually monitor things. They can help deal with corrections if they need to be taken, and the parent having access to that cell phone for that purpose is as important. And I'm going to wrap us here a bit because we're getting close to the top of the hour, but I do want to thank you so much for the conversation, Karen and Lori. Thank you so very much for your time today. And I'm going to quickly wrap us back to the presentation because Rhonda is going to come back on, I'm sure, in just a few moments. So to wrap up here, key plan design features that we've discussed. Preventive coverage for diabetes, give that some strong consideration. Chronic disease management, pass through rebates, allow treatment choice. This is a 24/7, 365 day a year disease. Here's some bonus features. Continuity of care. PBMs change their drug formularies annually, and the patient gets their chain yanked. And you're finally stable. It is a lot of work getting stable with diabetes. Making me change my drug regimen every year so that the PBM can make an extra $2 is not in anybody's best interest, honestly, except for the PBMs. Be quick about adjudicating a diabetes-related claim, especially if it's gestational diabetes, because that pregnant mother can't wait. Provide diabetes care and education as needed rather than a cap. You'll let people have smoking cessation plans as many times as they'll want. Don't cap diabetes care. This is a 24/7, 365 evolutionary disease. Your body's changing. Let them have what they need. Eliminate and minimize spreads on generics. This is something that Karen touched on. $0 copay for generics. Metformin is the primary generic drug for type 2 diabetes. You can buy it for $4. If your copay is $20, you're overcharging for metformin. So I would encourage you, these slides will be up there for you to download and review. Examine your current plan. Look at the data to find out what your plan is currently paying for. Examine the indirect costs. Model your plan designs, and thank you so very much for your attention today.
Thank you so much, George and Aaron, and all of the presenters. Just excellent. And thank you all for joining us. And if you'd like to view it again, and I'm sure many of you will, it's a very valuable resource. It will be archived shortly on hr.com. We will also send you an email with your credit information and a link to the archive to watch it again. Please note that I have put a link in the chat area. A new browser is going to open when I close out this session with a link to a feedback survey. So your feedback's important to all of us. So please take a moment to fill that out. All right. Thanks again so much, George and friends, and take care, everyone.
Thank you.